So the title of the talk is Thinking Beyond Sugar and Diabetes. We're going to talk about smoking cessation and what healthcare professionals can end up doing, both from a regulatory basis and from a clinical basis on what you can do to end up helping to reduce the risk for your patients. Just going to click over here. My disclosures, I develop continuing education for a living, so I've worked with a variety of different companies, and I want to acknowledge Johnson & Johnson for allowing me to be here today and supporting this through an unrestricted educational grant. Our learning objectives, what we're going to cover in the next hour is we're going to review the impact of tobacco use in patients with prediabetes and diabetes. We'll talk, give you some background about diabetes itself. There's lots changing. It's really an exciting time to be in this space, and talk about the ABCDESSS and reducing cardiovascular risks. Effective methods of approaching the topic of smoking cessation. This is a common complaint by healthcare professionals that they don't have the time. This can be done very quick, very efficiently, and the patients are asking clinicians to do it. We'll talk about the different pharmacotherapy options, although none of the pharmacotherapy options have changed significantly over the last few years. The way we're using these drugs have changed dramatically. And we'll discuss strategies to reduce cardiovascular risk in people with type 2 diabetes. So let's start with some of the new diabetes background. And this is an exciting time to be working within diabetes itself. Many things are changing. Just recently, I'll go through this in terms of a background. First and foremost, we have diabetes is a worldwide epidemic. We have a tremendous amount of individuals developing the condition. 1 in 11 adults globally have diabetes at this point. The International Diabetes Federation estimates from 2019, we had 463 million. By 2045, we'll have over 700 million adults. In 2019, 1 in 2 people with type 2 diabetes were undiagnosed. This is worldwide. And about 1 in 3 Canadians have either pre-diabetes or diabetes today. So these would be Canadian adults. There's an interesting debate that's happening within the diabetes space over the last little while is the impact in terms of cardiovascular disease. Is diabetes truly a sugar disease or a cardiovascular disease? And we're seeing more and more leaning towards the impact on cardiovascular disease. It's likely a combination of the two. But patients with diabetes are 2 to 4 times higher developing a cardiovascular disease than a person without diabetes. Diabetes itself causes 30% of strokes, 40% of heart attacks. And people with diabetes are 3 times more likely to be hospitalized for a heart attack, stroke, or heart failure. Diabetes, if you look at it, we focus a lot on the sugar, but in reality, 2/3 of the death in patients that that have diabetes that die of cardiovascular disease. And on the right-hand side of the slide, you can see the mortality risk in terms of diabetes, of cardiovascular death and of all-cause mortality. So it has a tremendous impact in terms of the overall outcomes, including, again, cardiovascular deaths for those patients with diabetes. Diabetes doubles the risk of almost every event. So if you're not familiar with these type of plots, it basically shows that it's almost double the risk for heart attack, stroke, and other types of vascular deaths. One of the key things that Diabetes Canada has done is really focus on the ABCDESSS. And this is designed for cardiovascular protection. This would include A1C, so trying to get the person to getting the sugar into target, tight blood pressure control, good cholesterol control, drugs to specifically help to reduce the risk of heart disease and stroke, and this has changed dramatically just in the last month, exercise, screening for complications, and you can see smoking cessation is clearly listed here, as well as self-management. On the right-hand side of the slide, we have the drugs for cardiovascular protection. I don't think it's overly relevant, and I'm happy to share my slides if anyone wants to see them. These are all available through the Diabetes Canada website at guidelines.diabetes.ca. Recently, this was just a few weeks ago, Diabetes Canada published an update to the pharmacological glycemic management of type 2 diabetes in adult. It's a great paper. I would encourage you to take a look at it. They've come up with guidelines as well as a companion piece or a user's guide, which is really quite a new way of doing this one. Is what do you do in terms of these guidelines? How do you implement them within practice? Very useful, very practical implementation guide for clinicians. Again, I'm not going to go through this in a lot of detail, but this is a new algorithm for managing patients with diabetes. What we're seeing now is just heart failure, cardiovascular disease, and many of these other conditions are now taking a high priority in terms of the overall algorithm, because some of the drugs that we use to manage diabetes have tremendous effects on lowering the impact of lower the risk of a heart attack, stroke, heart failure, and chronic kidney disease in patients. Why I put this algorithm here, one of the key things that they've done is that in patients with underlying cardiovascular disease, chronic kidney disease, or heart failure, or in patients who are over 60 years of age that have 2 cardiovascular risk factors, avoid tobacco use. So again, smoking is coming up, and a lot of these things in terms of our management of our patients with diabetes. So we can have a huge impact on reducing the risk of our patients with diabetes by implementing smoking cessation in a standard consult with our patients. So let's give you a bit about tobacco background. And there's a lot here, again, that's changed over the last little while. What is scary is we look at the numbers from 1999 all the way through 2017, we're seeing an increase of actually tobacco use. So we've had this steady decrease over this period of time, but we're starting to see this increase again in 2017. That's the last data that we end up having. The age group is kind of bumming me out a little bit when I look at it. Is you were hoping that, you know, the younger smokers or the young adult smokers would actually see, you know, at really low amounts. And we tend to see is that some of the people that have had this addiction for a period of time, they'd be higher amounts. But you can see in terms of the figure on the left-hand side of this slide, is consistent amongst many of these individual age groups. And most of these people are daily smokers. Depending on your region of the country, the province that you live in, you can see the smoking rates are quite different. Ontario and PEI have some of the lowest smoking rates, and whereas Newfoundland and Alberta have much higher rates. So about 1 in 5 people in Newfoundland or in Labrador are current smokers. Now, there are some key facts I want to get across for everyone, is that the majority of patients have a desire to quit. If you ask them, 2/3 will say, I want to quit within the next 6 months. A common misbelief is that smokers don't want to be harassed or bothered about this, but 85% of patients expect and want their healthcare provider to bring up smoking cessation. Again, you'll hear patients will say the best way to quit is to go cold turkey. This is an addiction, like many other addictions that we manage or substance use disorders. It's very difficult to do this on your own. And 2% will want to quit and remain smoke-free. Only 2%, excuse me, will quit and remain smoke-free without assistance. So they need your help. So without trying to go on a cold turkey basis, most of these patients will have a very difficult time maintaining long-term quits. And brief advice can increase the quit rate by about 66%. And I'm going to demonstrate what brief advice is for most of these patients. This is a graph showing the impact, and this was looking at a presentation that was done in London. So it's, again, GP practices. So if they went in to see their family doctor and the family doctor didn't say anything, the odds of quitting versus nothing at all was 0.65. So it was a reduction of about 35%. If they were advised to quit, so Mr. Smith, I think it's a good idea for you to quit, but help was not offered. We're not going to give you any support or any help. It did help, but it's, a 16% chance of reduction of quitting. But if the person was able to get help and support, it increased the odds of quitting by 1.3 or 30%. And what's interesting about this is that we think about smokers as being these diehard, that I really want to be a smoker. I'm a happy smoker. I feel very comfortable doing this. And that just doesn't reflect what the data is showing. The majority of smokers within Canada, want to change their smoking behavior. So I'll start from the left-hand side of the slide. So if you look at cigarette smokers, only 13% within the survey that was done are happy smokers. I'm smoking, I'm happy. I really want to, I don't want to do anything. I just want to smoke the same amount as what I'm doing. It's only 13% of the smokers, whereas some that would like to reduce is about 43% of those. About half of the others would like to, and about another half would like to quit completely. Moving over to the vaping, which is becoming more of an issue, we're seeing 18% of them are happy smokers, but majority of them would like to either reduce or to quit completely. And the time frame for action on dissonant smokers, they're undecided when they'll change. They just want to change. Some of them are planning to change behavior, and some of them are actively changing behavior. So it gives you an idea that these people really want help and support to help them quit. I'm not going to go through this in a lot of detail. There's a busy slide as we talk through it, but the impact on smoking is significant. It is one of the key causes in terms of preventable diseases, and it has an impact on almost every health system. Almost every cell and over every system in the body can be impacted by smoking. It increases cancer risk, lung cancer being one, cancer being the #1 type of death within Canada. We have oral cavity, laryngeal, esophageal, stomach, kidney, bladder, and cervical. It increases cardiovascular disease, the #2 cause of death in Canada. Ischemic heart disease, stroke, vascular, so important, as I mentioned, for patients with diabetes. Increases respiratory. COPD is #3 in terms of preventable death. And almost every patient that has COPD, smoking has some type of link associated with it. And it's one of the only interventions that we can have in a patient with COPD, which may slow the progression of the disease. Most of the pharmacotherapies that we have at this point just help to manage symptoms. They don't treat the underlying problem. Where if a patient, regardless of where they were, in terms of if they have severe COPD, mild COPD, the earlier we implement smoking cessation, the better off that individual will be. It can impact reproductive health, erectile dysfunction, pregnancy, low birth weight, SIDS in terms of outcomes for that. Have significant other outcomes in terms of patients, peptic ulcer disease, impaired wound healing, tons and tons of impacts in terms of smoking. And it's not just a smoker. You can see with secondhand smoke, there is some link associated with things such as SIDS or increased risk of cardiovascular disease. This is why we want all of our patients to stop using tobacco. Tobacco use can, again, have impact across all of these individual conditions. And what will happen in an individual patient, it will really depend on them. So some of them are very fortunate, and others will end up seeing multiple impacts in terms of their tobacco use. So why quit? And this is kind of a neat slide that a lot of people ask. So, if I quit today, what's going to end up happening? And this is some data that will come up and talk about the benefits of quitting. So if we look at within 24 hours of stopping the smoke, the patient's blood pressure and pulse may drop. Within 48 hours, the carbon monoxide levels may return to normal at that point. By 3 months, lung function may start to improve with decreased cough, sinus congestion, fatigue, and shortness of breath. And this is one thing, just as a practice tip to let you know, is that when patients will stop using tobacco, the coughing may intensify for them. And they may be wondering what's going on. This is awful. It's the reason why is that the cilia that was within the lung cavity, it's actually starting to clear some of the mucus and basically I would say garbage within the chest. So allowing the person to cough it out. So they may cough more frequently when they first start to quit. This is a normal type of experience that they would end up experiencing. But when they get to the 3 months, we'll see that improvement, decreased cough, sinus congestion, fatigue, and shortness of breath. By 1 year, the coronary artery disease risk, excess risk is reduced 50% among ex-smokers. By 5 years, their stroke risk returns to the level who have never smoked at 5 to 15 years post-cessation. At 10 years, their lung cancer risk is 30 to 50%, so anywhere from a quarter to half of what those is compared to people that continue to smoke. And the coronary artery risk at 15 years is similar to people that never smoke. So you can see the benefits of this extend from short-term outcomes in terms of the way they feel to a massive impacts in terms of their overall health as they continue to become non-smokers. So let's look specifically at smoking and diabetes. How do these topics relate together? So tobacco increases the risk of people developing type 2 diabetes. So smoking increases the risk of type 2 diabetes by about 30 to 50%. So this is a study that looked at the relative risks of what would end up happening for people 50 years. Like they looked it over in terms of the health consequences of smoking. This is a 50-year, this is a Surgeon General report that came back a few years ago. The relative risk of developing type 2 diabetes in a person that never smoked was considered 1. So how does a person that never smoked comparison to a former smoker? So you can see the former smoker is slightly increased their risk by about 14%. If the person is a current smoker and is a light smoker, it would be about 25% increase, or a heavy smoker is about 1.54. So you can see it's about 50% increase in terms of the overall risk. Now, I always get this question. It's like, well, most smokers are typically leaner, right? This is a stimulant. So, why are they ending up getting this and why do they have this increased risk? And the belief is that smoking increases central obesity. And central obesity or visceral fat that's sitting there would increase the risk of diabetes. But also smoking increases inflammatory markers and oxidative stress. This has been linked to insulin resistance, glucose metabolism irregularities, and this increases the risk of developing either prediabetes or diabetes in those individuals. Busy slide, I'll kind of talk through some of the key points just if you're educating individuals with this. So what is the relationship with diabetes and smoking? Decrease in terms of insulin sensitivity. So there's increase in counter-regulatory hormones or circulating hormones of insulin antagonist hormones, catecholamines, cortisol, and growth hormone. Impaired control of glucose and lipid metabolism, increase in blood pressure, total cholesterol, and increased obesity, increased risk of hypoglycemia in your patients with type 1 diabetes, increased risk and progression of microvascular complication. Really here is the kidney is being the key issue here in patients with type 2 diabetes, increase the risk of coronary heart disease, stroke, peripheral vascular disease in patients with type 2 diabetes, and increasing the risk of cardiovascular all-cause mortality in patients with type 1 and type 2 diabetes. So you can see the impact is so significant in terms of your patients with diabetes. So this is kind of a cool one that they end up doing, looking at the relationship of smoking and total mortality and cardiovascular events among patients with diabetes. This was a meta-analysis systematic review that was published in 2015. They looked at current smokers. What is the relative risk comparison to non-smokers of ending up having these bases, both with diabetes? So in current smokers, it was 1.55. So it's 55% increase of the overall risk comparison to a person with diabetes that wasn't a smoker. Cardiovascular mortality was about 50% higher. And you can see all the way along that even something like peripheral artery disease, it's about twice as likely in a patient who's a current smoker versus a person with diabetes who doesn't smoke. But what's more important for this one is if we move over to the other part of the slide and look here on the on the right-hand side, you're looking at former smokers. So what is the benefit of somebody who quits? And they end up looking at this one. So again, current smokers versus total. So if you look at the numbers, total mortality is 1.55 as a relative risk versus a 20% increase in risk. So it's a 30% reduction in relative risk of total mortality. Cardiovascular mortality goes down, total cardiovascular disease goes down significantly, coronary heart disease goes down, and stroke goes almost back to normal in former smokers comparison to 1.5 times the overall risk in patients who are currently smoking. So significant impact if they actually quit. Significant impact in terms of their overall outcomes. So if they want to live long-term in terms of with patients with diabetes, it's one of the significant interventions that we can end up doing to end up reducing the risk of these macrovascular or cardiovascular complications. The kidney is one that's interesting. We're seeing more emphasis on kidney and diabetes. Wherever the heart goes, typically the kidney follows. So albuminuria, albumin, if you're not familiar with it, is a really large protein that circulates in our blood. And our kidneys should not be spilling any of for this protein because it's large. If we see damage in patients with chronic kidney disease or in patients with diabetic nephropathy, we'll start to see a breakdown in terms of the membrane, and we'll start to see albumin excreting into the urine. And it's a measure of a poor kidney function typically in these individuals. But patients who smoke, they had an increase of the spillage of this protein into the urine, worsening of the nephropathy, increased risk of kidney disease, but that is with this microvascular complication. Neuropathy, so which is where we get the nerve damage associated with diabetes, and retinopathy, eye damage associated with diabetes, not as a strong association with smoking in comparison to the kidneys and the heart. So the real advantages of there's so many health advantages from patients quitting smoking, but for diabetes specifically and diabetic complications, the key ones here we're going to focus on are cardiovascular disease and chronic kidney disease, where we reduce the overall risk. So smoking cessation diabetes therapy is one that comes up quite often. So in patients who are taking oral antihyperglycemics or injectable drugs such as GLP-1 receptor agonists, it really doesn't have much of an impact overall. But in patients taking insulin, it can decrease the subcutaneous absorption of insulin. So some people may need to adjust their insulin up or down depending on what's happening to them when they're quitting. And the reason why also is that smoking is very stressful for an individual. If you have a substance use disorder and you remove that substance associated with it, it leads to stress. We see this increase in catecholamines. So we have all this extra, these are anti-insulin hormones. We can see an adjustment in terms of the overall level. So you may need to have these patients to adjust their insulin dosing. So we want them to test more frequently. I'm a big fan of things such as, if you're not familiar with them, things like flash glucose monitoring. that can be used, or continuous glucose monitoring. The most common examples would be the Abbott Libre or the Dexcom 6. These are devices that measure the person's interstitial fluid, or the interstitial fluid for glucose, and gives an idea of what's happening so they can see if they're going up or down. It gives them those trends. What we should be doing for our patients is really looking at intervening often and frequently, and let them know that we're here to support them. If they're at risk of diabetes or have pre-diabetes, smoking cessation may help to lower their risk. And that's just a key message that we want to hit over and over again. And I'm a pharmacist. There may be some physicians, some nurses that are on here, public health professionals that are here. The more people that intervene and actually get across in terms of this consistent message, it can make a difference. It can have a huge impact. What patients are going to see is that they really want and expect healthcare professionals to provide them that information and guidance. With this one also, patients with diabetes are high risk of cardiovascular disease. Quitting smoking can reduce their overall risk. So these are just kind of the messaging we want to get across. We'll talk about smoking cessation therapy, although our toolbox really hasn't changed in terms of the tools we have to manage smoking cessation. The way we use them has changed dramatically, and really specifically nicotine replacement therapy is very different than when we started. Bupropion can be used. So Zyban is the trade name for this individual product. For most patients with diabetes, we just have to be careful with some of the drug interactions. And I'm really anxious about using it in patients who are using sulfonylureas. So this would be glyburide, gliclazide, glimepiride, or using insulin, because in patients that get hypoglycemia, it increases the seizure risk associated with this drug. Whereas Champix or Varenicline or nicotine replacement therapy would be perfectly fine in patients with diabetes. So let's talk about smoking cessation and what's changed so much over the last few years. So first and foremost, we used to have a 5A approach to smoking cessation, and what's come across the pond from the UK is VBA, very brief advice. 30 seconds may be all we need to end up having to reduce or improve somebody's life, and it's quick. You just ask and record the patient's status. This is a significant barrier for many healthcare professionals and many public health professionals. Just ask them. Do you currently use tobacco? Are you a smoker? Okay. Are you an ex-smoker or a previous smoker? Anything, just to document it on the chart. By asking, that starts the process. If the person says, well, yes, I use tobacco, then it's really advising the patient that the best way that if they ever want to quit smoking, is a combination of medication and support. Try to be non-judgmental, be supportive of this one. Again, it's a substance use disorder. We're looking at this as something that we can end up helping these individuals to be able to quit. Most smokers know the risks. They don't need to be chastised. You don't need to shame them. You don't need to go up to them and say, don't you care about your health? Don't you want to get your diabetes under control? Aren't you worried about your heart attack or stroke? They know these risks. And you see that in terms of the dissonance. They all want to quit. They just don't necessarily have the support or are not at that proper place to look at a reduction. They need assistance, and most of the time, not education. So you know what? The best way we can do it, if you're interested, I'm here to help you. And if they say, yes, I would like to quit, act upon it. Provide them in terms of pharmacotherapy and then counseling behavioral support to help them quit. It's really quick. And what they found is that you may have a patient that ends up coming up and says, well, I'm not really ready at this point. First and foremost, they know that you're ready there to support them and that they can come back to you at any time. This is not about shaming anyone. It's just about asking and documenting and, again, advising them that they can quit through a combination typically of pharmacotherapy and support. Busy slide, but I'll talk you through in terms of cessation rates with this one. This is an older paper that was done. This is the US Fiore guidelines. So this is smoking cessation guidelines that were published in the US in 2008. And they looked at how do these drugs compare to quitting cold turkey. So cold turkey, as I mentioned, is very, very difficult to do. Most people that do use cold turkey will typically end up failing because, again, it's a substance use disorder. These patients will have withdrawal symptoms that make it very, very difficult to actually manage. All pharmacotherapies, what they do is they actually help the patient to manage the withdrawal type symptoms to allow them to do the behavioral changes. So again, what happens with smoking, it's so ingrained in terms of these individuals' lives. So it's quite common if you start to talking to your smokers, what you'll find is they'll say, I know on my drive into work that at this telephone pole, if I light up at this point, I can have 2 cigarettes before I get into work. They have this so ingrained in terms of their overall basis. So when you remove the tobacco and you have them go cold turkey, they pass by that lamppost. Not only are they thinking about tobacco at that point, but if they're trying to do this cold turkey, they're having withdrawal symptoms. So they're feeling uncomfortable. What's the way to get rid of withdrawal symptoms? You initiate smoking again. So this is why many of these patients have a difficult time. Where current pharmacotherapy, what it does, it helps for withdrawal symptoms so the patients can focus on the behavioral changes. Okay, so in terms of this chart, there's lots on here, but the key things that we want to look at is most smoking cessation-based products as monotherapy, they double the risk of patients being able to quit. Where Varenicline or Champix triples the risk as monotherapy. Combination therapies, which is what we're promoting, you can see with using nicotine patch plus gum or spray, is very equivalent in terms of Varenicline or Champix in terms of the overall products. So any of these products will end up helping. So I find that one of the biggest things that I see with healthcare professionals is they'll say, well, I like Champix, so I'm going to give it to all my patients. But Champix may not be the most appropriate choice for individuals. Or I like the patch, and I give my patch to every patient. Well, that may not be appropriate for everyone. The key thing here is to find what the patient needs and then adjusting according to that. And we'll talk you through some of the key things that are here with this. This is such a neat slide, and it really adds to it. And I'll explain to you, when we thought in terms of when patients smoke, is when you smoke, it's such an amazing delivery system in terms of medication. So the way the nicotine comes out from the patch, the way that the cigarette has been designed is so that the nicotine gets to a really high level, it gets into the lungs and right up into the brain within just a matter of seconds. So it's when you're using anything for a substance use basis, so whether it be nicotine or a drug like heroin, you want high dose with rapid absorption in a very short period of time. So what we thought is that when somebody would smoke, you would go up and then it would go all the way back down. The patient would have withdrawal and they will smoke again, and they'll just keep going up and down, right? So that the patient would go from, say, on an arbitrary from 0 to 100, back down to 0, feeling withdrawal symptoms, smoke again, and it would go down. That's not what really happens. This slide actually gives you a better idea of what's actually happening across. We have a patient will actually have that first cigarette in the morning where their levels are absolutely the lowest. This is they haven't been smoking overnight. You know, if they're smoking, waking up to smoke at night, this is usually a sign of very, very strong addiction for those individual patients. But you can see from this, when we start at 9 o'clock, we have that first cigarette, the plasma levels will shoot up to 40 for this individual patient. But we don't go all the way back down. So the plasma levels you'll see will go down to 20, and then they'll smoke again. And each time it's not going down to the lowest point. And the reason why they're doing it is that patients or smokers will actually self-adjust so they don't have severe withdrawal symptoms in the morning. So they keep moving their level up and up and up and up and up throughout the day. And then what they get to at the time when they're just before they go to bed, they have that cigarette so that, again, they have a high nicotine level so they don't have the severe withdrawal symptoms in the morning. So they're constantly adjusting in terms of those levels. So it's very easy with these products to self-regulate the levels so the patient doesn't have these type of withdrawal symptoms. That's essentially what they're doing. The patch is probably the most, NRT is probably the most flexible in terms of overall dosage forms that you can recommend for patients. We have patches, which are long-acting, and we have a lot of short-acting products. We have gum, lozenges, inhalers, and we have quick mist spray. If you're a clinician, the way to visualize this is the same way if we were managing a pain in a cancer patient, the patch is more like an SR formulation, so slow released over that period of time. Where the short acting are those for those acute pains, or this is acute cravings for these individuals. And I apologize if my dogs, if you hear them in the background. Then this is another more recent paper that actually looked at how effective these different NRT forms are. So people ask, which is better, the gum or the lozenge? Which is better, the patch, or should I be using the quick mist spray? In reality, they really kind of show the comparison here. So different pharmacotherapies, Zyban versus the patch, they're pretty much exactly the same. Varenicline or Champix versus the patch alone, Varenicline is more effective from that standpoint. But for most of these patients, we're actually using more combination therapy. So patients using combination therapy versus single form of NRT, so this is on the right-hand side of the slide, it's significantly more effective for those individual patients. And short-acting alone versus nicotine patch, they're close to the same, but generally nicotine patch is more effective because it leads to a more consistent level for our patients. So this is not typically what I would recommend for patients who are quitting smoking using NRT. The key learning point from this is that really any type of pharmacotherapy, be it Zyban, be it Ziazibam, be it Champix, or being NRT, they double the chance of quitting. Combo NRT triples a chance, which is very similar to, again, to Champix. And combination therapy plus counseling is 5 times the overall risk of a person being able to quit. This is the biggest change that we'll see, and there's a lot of words in the slide, but I'll just talk you through the key components. When we started, you can see looking at my hairline, I've been around for a long period of time. So when I started out and the patches first came to market, you would think, okay, person would put the patch on. And at the time I lived in Sudbury, Ontario. So I worked with a variety of people for all different demographics. So we had all these people that wanted to quit January 1st. That was the first day. And they all would come in looking for the patch. And they would come in, they would put their patch on, and we told them, okay, now you have to quit. You can't have any more cigarettes at this point. Otherwise, you're going to have a heart attack or stroke. So what ended up happening, and for the clinicians that are here on this webinar today, is that they would come up and they would say, I'm having a craving. So what they would do is they would rip off their patch, have a few cigarettes, and then put their patch back on. So it really didn't work overly effectively for those individuals. What we do know now is patients can continue to smoke when they're using these products. So we don't have to go from 20 to 30 cigarettes a day. That's a lot of puffing, to 0. We have some flexibility in terms of what we can do. So the old way we did this is that on quit day, you would say, okay, in the next 30 days, pick a day. So I'm going to pick Halloween. So on Halloween, the person would throw on their patch, and then they would stop smoking and throw their cigarettes away. That is one of the older ways to do it. It's not typically overly effective for a lot of individuals, but some people will end up doing it that way. The next one is reduce to quit. So this is kind of a cool way of ending up doing it. So you do the same thing. So if you can come up and say, in the next 30 days, pick a time that you want to end up quitting. So again, arbitrarily pick Halloween. So right now, we would start to put you on nicotine replacement therapy. And the goal here is to have the person reduce the amount that they smoke towards their quit date by anywhere from 50 to 75%. So you'll find that they'll end up using less because they're having nicotine that's being supplemented within the patches or the gum that they're ending up using, or any of the other products. So this makes it so that they're not at 20, they may be at 5. And this may be easier for them to go to 5 to 0 versus that. The last one, which is kind of a really interesting one, is so you saw in those dissonance charts that some people are not really ready to quit at this point, they just want to reduce. Well, what we can do with the products now, and they have indication for, is that you can actually just reduce the amount they're smoking. And the amount of tobacco that they're consuming is really directly linked in terms of the overall risk with these individual products. So the less that we end up using, generally the better it is for their overall health. So with this, we would actually have the patient just apply the patch on, or use gum, lozenges, Quick Mist, any of these individual products. And what that would end up doing for them is that they would find that their cravings are not there, so they'll just end up using less. The goal here is just to actually reduce over a period of time. So they use the two of them together, and then you'll see that the decrease in terms of tobacco goes down and an increase of NRT. So it gives some flexibility in terms of what we can do for our individual patients. And this is the most significant changes that we're seeing in terms of these products, is the flexibility that we have with them. This is the STOP algorithm. This is something that Peter Selby developed in 2016. And one of the key things that we thought is you put on 2 patches, that was going to lead to a huge amount of problems for an individual patient. What we realized is that the more the person smoked, the harder time they had to quit. So a light smoker, somebody is smoking less than 10 cigarettes a day, they would use a 14 milligram patch, which is a middle patch. Somebody who's a moderate smoker, 10 to 29 cigarettes per day, they would use one of the high dose patches, 21 milligrams. But if you're a really heavy smoker and you're smoking, these patients are smoking 30 or more cigarettes per day, they would likely need multiple patches so they don't have withdrawal symptoms. Because there's nothing worse than you have a heavy smoker, say throw a patch on, and again, if they were smoking more than 30 cigarettes a day, it will not supplement their nicotine level enough, and these patients will start to have withdrawal symptoms. One of the key things that are different to what we used to do in the past is we used to only use one form of NRT. Now we're using multiple forms. So remember, long acting versus short acting. So let's say a patient here is a moderate smoker, they're 10 to 29 cigarettes a day. We'd give them a 21 milligram patch, tell them to put that on, but we would also give them the gum, the lozenge, the mouth spray, or an inhaler, the spray, the mist, that they can use when they have cravings, because these are rapid acting. So I'm having a craving, I'm having some withdrawal symptoms, I can end up using that product while using the patch so that I don't end up starting to smoke again. And this is that flexibility that the patients feel they have some control in terms of what's happening with them. What's interesting is that they recommend follow-up in the algorithm, and this is consistently what I recommend for clinicians to do within practice. But if the person is still smoking at 1 to 4 weeks follow-up, we just add more patch to them. So similar to what we do for other type of conditions. So if they're still smoking 1 to 5 cigarettes a day, you throw in a 7 milligram patch along with their current dosing to ensure that they're covered and continue to use those short-acting products. The key question I get from a lot of healthcare professionals, what's the maximum amount of patch I can use? 4 by 21 milligram patches. So you can take 4 of these patches and put them on the same time. And this is for a really heavy smoker that has a high level of addiction to nicotine. So we have some flexibility in what we can end up doing for these patients. Fundamentally, the key thing is the more addiction that the patient has to nicotine, the longer that they've been a smoker for, so the more they smoke and the longer they've been a smoker for, typically the higher the dose of the NRT we have to use and the longer we have to use it to help a patient quit. So you can feel flexible in terms of helping those individuals. This is the Ottawa model. This is Dr. Pipe has developed a lot of this within Ottawa, and I highly recommend. Like, they just have done some amazing work within Ottawa to end up helping these individuals. What they do with their model, the easiest way to remember for patches is that you ask the patient how many cigarettes they smoke per day. And so they say, oh, I smoke about 25 cigarettes a day, or let's say for ease of doing it, say I smoke 20 cigarettes a day. So they look at as patch per patch. Milligram, 1 cigarette is approximately 1 milligram a patch. So for patients that are smoking 20 or more cigarettes per day, they recommend a 21 milligram patch. And you can see that with the algorithm here on the right-hand side. Again, as I mentioned, the higher the amount that they smoke, the slower the taper. So you can have some flexibility in terms of those ones. If the patient has withdrawal symptoms after 24 hours, you keep increasing to make the patient feel much more comfortable. What we're seeing now is just like we would do for somebody who has, say, an opioid use disorder, that we would use something like methadone or Suboxone for those individual patients that we want to keep them on the product, to keep them under control. There's less fear here that you get to 12 weeks, you have to pull these patients off, there's going to be these risks. Most of the time we can continue on these patients, on these products like NRT for a longer period of time as the patient ends up needing it. From Dr. Pipe, one of the key quotes that he had for this one is basically as much as they need on NRT for as long as they end up needing it. And that's such a great quote. And so you can feel quite comfortable as long as the patient is using less than 84 milligrams per day of the patch, you're within that range. And there's very few people that would actually use that amount. You saw this graph already before, but the difference here is what's the logic behind using the patch in combination therapy. So you can see where the red line comes across here. That's the amount of nicotine that applies for within the patch itself. So you can see as you apply it on, it just slowly increases over the level and keeps that kind of consistent level over that period of time. But smoking, you can see where the person smokes, the levels shoot up. Well, what we would do here is we would use a short-acting product. So this is a patient, say, for example, looking at 10 o'clock, they had a cigarette at 10. Instead of using a cigarette, we would use a short-acting NRT product to end up helping for that craving. So you can see how we can be really flexible and customizable based on those patients. People who smoke are just like the rest of us. They have good days and they have bad days. So they can be very stressful and they end up wanting to having to have a very stressful day at work. They want to have a cigarette. They can be, with these short-acting products, be very flexible in terms of the amount that you can give them to accommodate for that. Common myths, and I would love it if everybody that's on the webinar today, if they were able to correct this. So first and foremost, that NRT is not effective. A lot of people will have thoughts and feelings about NRT because this has been around for a long time. I've been a pharmacist again for a long period of time. They'll say, I tried it before, it never worked for me. And the key thing here is likely was an appropriate dose. Many of these patients don't take it long enough, and which we'll talk about in the next few slides. And what we do know is that it doubles the chance of the person quitting at 6 months. Long-term nicotine replacement therapy isn't safe. Up to 6 months is what's on label. We have many clinicians that will use it beyond that point, but you can comfortably use that as well. Nicotine can cause cancer and other smoking-related disease. It's not the nicotine that causes the damage associated with tobacco. Nicotine is what causes the addiction. So if we can pull out all the 4,000 other chemicals from using igniting products away from that and use just basically nicotine, we can help for the overall addiction and slowly reduce it over a period of time. And people will come up and say, well, when nicotine replacement therapy is just replacing one addiction for the other. Again, what we saw with smoking is that rapid increase with a rapid decrease. This is what patients that have use disorders are looking for, regardless of the drug. You saw with the patch, it leads to a very slow increase over that period of time. So it doesn't necessarily, it will not be associated with the addiction for the patients, but end up helping for the withdrawal symptoms. Key thing from an education standpoint is about 50% or less of users adhere to the treatment therapy. So even if you prescribe 8 to 12 weeks or recommend 8 to 12 weeks of this, many of the patients will just stop it. And this can have a huge impact in terms of the overall efficacy. And you'll see that from the slide, patients that use it for less than 4 weeks, again, quitting success rate, improvement, they have negative impact. Using it for 4 to 8 weeks, it doubled the increased risk. Using it for 8 to 12 weeks is 4 times the overall increase. So it has an impact in terms of it. It's the key thing is just doing the follow-up and adjusting based on what those patients need. Key points: non-prescription, over-the-counter patches can provide consistent throughout the day. Gum, lozenges, hail or mist, rapidly managed. You can customize based on those individuals. Many different ways of using the product. Ensure that they have that 10 to 12 weeks and they can use longer if they need it, and to review the adverse effects. The other thing too is the way that they're administered. If you're recommending a patient to buy this over the counter, tell them to talk to one of the pharmacy staff members that are there to ask them how to use the lozenge or the gum. They don't want to chew it like regular gum. This can lead to bleeding into some problems, or biting down on the lozenge can lead to some issues for them. It's important that they use it appropriately. Otherwise, they're at higher risk of adverse effects, and it doesn't work the way that it's intended. So what about Bupropion or Zyban? And this has been available for a long period of time. So Zyban itself is first and foremost an antidepressant drug. And we're using it for a variety of things. It's actually being used right now in combination with another drug to end up helping for patients for weight reduction. The way it's taken is it's 1 a day for 3 days, and then 1 twice a day. Probably just for the short form. Twice a day, 1 in the morning, 1 at night for up to 12 weeks. And it can be taken longer if required. Way this drug works is that it stimulates the dopamine, which is that euphoria, that great feeling that people will end up getting. And what it does is it actually stimulates that on a consistent basis. So it actually helps with that overall craving. What's cool about this drug is that you can combine it with NRT. So if you want to use Zyban for patients had very good success rate with Zyban, but they had trouble with cravings and they restarted, you could use a short-acting product, NRT product along with it. So you could use something like the gum, the lozenges, the spray for those individual patients. They usually start at 1 week before the quit date, and they can quit on that date, or they can continue to reduce over that period of time. The biggest issue as I mentioned, is seizure risk in some individuals. Medications that increase seizure risk, a few of the drugs like amitriptyline and a variety of others, or the patient has a history of epilepsy, or if the patient actually is in diabetes, if they're on a drug that causes hypoglycemia, this would be the sulfonylureas like glyburide, glycoside, glimepiride, repaglinide, or on insulin, this would increase the risk of seizures. The most common side effects are dry mouth and insomnia, and in a few slides, I'll show you how to manage those if you have them. The next drug is Varenicline, and this is kind of a cool drug in the way that it works. It goes in, it's what's called a partial agonist. So it goes in the spot where nicotine will go in, and it just kind of plops into that spot. So the nicotine will come up to this receptor and sit and come up here, and this causes the stimulation of the dopamine that's released. What this drug does is it comes up and it sits there, and it will block any nicotine that comes in. It blocks it, but it will release a little bit of the dopamine for that individual. So what they do is that it's enough to usually help for the cravings, but if they smoke, they don't get the euphoria for it. So if they continue to smoke, what will happen is they won't get that rush that they typically want to end up having. So it has been quite successful in terms of the overall trials. The way it's taken is 1 a day of the lower dose for 1 to 3 days, at twice a day for 4 to 7 days, and then we go on to the higher dose at 2 to 12 weeks. The reason why we do this, nausea is a very common side effect associated with this drug. Originally, we thought you couldn't take this with nicotine replacement therapy. The data is out there that it's no problem at all. You can use this with nicotine replacement therapy, just like you would Zyban. So if the patient's having cravings, no problem at all. If they want to use gum or lozenges to end up helping to support them with their cravings, not an issue for that individual patients. You want to the quit date should be started at least 8 days prior to stop. So it's about 7 days before. And again, you can either do it as a cold stop or have the patient slowly taper after that quit date. One of the key concerns they have with this drug when it came to market is that a black box warning saying, if patients have a psychiatric issue with this one, you can't, it's contraindicated. All of that's been removed. And the reason why is you can imagine anytime you have a substance use disorder, you quit, it's a tremendously stressful time. And those patients just quitting alone puts them at higher risk of developing psychiatric concerns. So not a contraindication, but a reminder that if you have a patient that's quitting smoking, to follow up them on a consistent basis, because they may be having some challenges of going through. And again, monitoring and follow-up can end up helping for that as well. As I mentioned, you can quit abruptly, reduce to quit, or reduce smoking. So if you want a patient that you just want to get them down a little bit, this could be used the same way that we did with NRT. Adverse effects with nicotine replacement therapy, the most common ones that we see with short acting are here. So it would be, and a lot of times through inappropriate use. So the gum, the way it's used is you bite down twice, and then you park it right here in the cheek. You bite down again, and so you get either a peppery taste or a couple of times, and you park it. So the average piece of gum should last approximately 30 minutes. The lozenge should be slowly sucked on over that period of time. They don't want to swallow it, and they don't want to end up biting on that basis. The spray, if they spray it inappropriately, it can actually irritate the throat. So the most common ones that we see are here. So some patients will have hiccups, some patients will end up having sore mouth that's associated with it. Appropriate use of these products can reduce that overall risk. The patch, one of the key things we see in some of our patients have sensitive skin, especially we're getting into the winter months. They can end up having a rash that appears on it. Things that can be done for that is site rotation is the most important thing. So if they use a spot here, they cannot use that same spot for 7 days afterwards, but they can move up just a little bit above it. It's usually used in the upper areas of the chest. It's usually here, avoiding the breast area for individuals. If they develop a rash, topical cortisone, you can buy this over the counter, this hydrocortisone, or prescription-based products can be used to help for that rash. Bupropion, the most common side effects that we see with this are insomnia and dry mouth. Drinking water will help for that. And we want to take that afternoon dose. No, it's usually done in the early afternoon. They have to be spaced at least 8 hours apart, but you don't want to take it at bedtime because that can worsen insomnia. For Champix or Varenicline, you want to take it on a full stomach with a glass of water, full glass of water to wash it down. It dissolves it, so it's not all that drug that's sitting in one spot in the stomach. And having the second pill at supper time rather than at bedtime, this would reduce insomnia. Drug-drug interactions, nicotine replacement therapy, there's no significant drug interactions for most of those individuals. The key concern that I have is not with the therapies, but a patient taking insulin, as I mentioned in the beginning. If you have a person that has type 1 diabetes on insulin and they're going to be quitting or reducing, get them to monitor more frequently because you may need to adjust the insulin for those individuals. Varenicline, generally, I'm very comfortable for most of the patients who have complex polypharmacy, lots of drugs. It's usually not an issue. Patient has severe renal impairment, we're a little bit more concerned, but generally, it's got a pretty good drug interaction profile. Bupropion, because it's an antidepressant drug, because it works, and there's lots of drug interactions with it. So you can see why we're kind of going away from using Zyban for a lot of these patients, and we typically will use NRT and Varenicline. That being said, Zyban is a very effective drug, and for some patients, they like it, and especially if the patient has underlying depression, because it's an antidepressant drug, this may end up helping for that as well. Bottom line with all the pharmacotherapies, all are effective. All of them. So I want people to think of this as just a really kind of a cool toolkit that they can end up using and customizing for those individual patients. Completely customize it for that individual, looking at adjusting the pharmacotherapy based on what the person is smoking. And if they're having any issues, you can kind of move it up and down. Patient can continue to smoke if they're using these therapies. The goal here is we want to reduce over this period of time. All people who are interested in quitting smoking should be offered medications to quit. This has been shown to increase the risk. If they increase the odds of them quitting, especially at 6 months, we really want them to focus on this one. It's one of the most effective things that we can end up doing to help our patients. Nicotine withdrawal symptoms, I always like to throw in the slide because we get these questions quite often, is what can I expect? And you can see from the slide, it's in terms of what is going to end up happening in terms of persistence of cravings or withdrawal symptoms. So the duration of increased appetite, about 70% of patients who are quitting will end up having that, and that can last up to 10 weeks. So we want to make our patients aware of it. This is the key concern. So they're saying, oh, I'm going to gain all this weight, and this is really unhealthy. It's better for me just to quit smoking. The data is consistent. If they gain a few pounds, which likely they would, we're taking a stimulant away from them. Any of the risk from that weight gain is significantly lower than if they continue to smoke. You can see here that most of the patients also had craving for nicotine, but the duration was relatively soon. So it's like less than 2 weeks and then start to feel better. Depression, restlessness, poor concentration can persist for multiple weeks afterwards. Sleep disturbances, again, because we're pulling away a substance that they have a use disorder associated with it. So they can have all these ones, and they typically will dissipate over time. Pharmacotherapy helps for all of these ones because we're helping for the addiction for that individual. Again, pharmacotherapy to help for the cravings and the overall addiction that this patient is having. where they can focus on the behavioral changes. What am I going to do if I always have supper time and then I have a cigarette right afterwards? How am I going to adjust for this one? So we're going to get rid of those withdrawal symptoms so the patient's not in withdrawal and thinking about cigarettes. So they're not in withdrawal, so it's okay, how am I going to adjust my behavior after dinner? What am I going to do differently? So things that I would tell a patient, it's like, what I would, if they came up and said, well, we would, one of my favorite times that we'd have dinner, and then my husband and I would sit down and we'd have a cigarette, and it was just our relaxing time. So what I would tell them to do is little things. You can get up, just leave everything the way it was. Instead of going up and having this cigarette, maybe going outside on the back deck, going out for a walk, moving into the living room, taking that break somewhere else. Just pulling yourself out of the situation can end up helping to remove that behavioral type of issues associated with it. Small changes consistently over a period of time can really help these individuals. Slips and relapses, please, if I teach you one thing with this is that if you look at any substance use disorder, think of it as a chronic relapsing condition. These patients will commonly end up having relapses, and this can be very frustrating as a clinician because you could have a patient that you end up helping them quit and they could be smoke-free for 15 years, run through a period of time, or the story is I had a cigar at a bachelor party and then we just started smoking again. Previous quit attempts are good predictors of eventual success. So working with them, tell them not to feel guilty about this one. It's really, we're working towards this one. We're going to help them through this process. Don't worry about it. We'll just start from the beginning again. Understand the situation. Why did they end up getting it? How are they going to deal with it differently? Continued use of medication can reduce the likelihood of slips, especially if they just said, oh, they come into you, I had a few cigarettes over the weekend, or I bought a pack and I ended up starting using. Okay, well, that's a slip. So we don't want you to get into relapse. So why don't we start up our pharmacotherapy again, like we did before? So we'll give you some patch, we'll give you some gum, or we'll start up a course of Champix to end up helping you from that as well. Encourage them to go again, and let them know. For a lot of people, it takes up to about 5 times for them to be successful. As I mentioned, support is really important. All healthcare professionals, public health professionals can provide support to these individuals helping to quit. There are some great things like Smokers Helpline that can end up helping to connect to resources to give them that emotional support. Again, help for those behavioral changes. Every little bit helps. I can tell you from a pharmacist perspective, every pharmacist in the country has the tools here that can end up helping. So if they have issues with this, they can rely on it. But again, the more people that work at this, the better off the patient's going to be. So to finish off, and then I'll get to the questions that I end up having, is cardiovascular risk reduction is crucial in patients with diabetes. Smoking cessation is a key component of that. It can reduce the risk of type 2 diabetes, renal and cardiovascular complications. Again, cardiovascular disease causes the majority of death in patients with diabetes. Smoking rates have recently increased in Canada. It really bums me out in terms of what is going to be the health impact of that, both in the short term and in the long term for these individuals. Short interventions, you don't have to sit there, although longer interventions are very effective. Short interventions is what most healthcare professionals have. Short interventions are generally effective, so 30 seconds can save a life. You remember that can end up helping for these individuals. Currently approved pharmacotherapy options are effective for smoking cessation. As I mentioned, the ones that typically used in patients with diabetes would be the NRT, nicotine replacement therapy, or Varenicline or Champix for those individuals, generally safe across the board. The only concern I have with Varenicline and diabetes would be in patients that have chronic kidney disease. That would be my primary concern. And I would encourage you to customize your treatment plan based on the needs of the patient. So on that note, that finished off the majority of my presentation. I have 5 minutes left. And first and foremost, I want to thank everybody for attending. And I'm going to jump into the questions that I have. So the first question I have is on the macrovascular slide. How long does a patient have to quit to reach the reduce risk levels reported? So the reduction in terms of overall risk, I don't think there was anything reported in terms of how much the overall time. I can have to pull up that paper, but I think that's what they did is they just did as a systematic review and meta-analysis in comparison to all of these people. So they just identified who was a former smoker, who was a previous smoker, and who is a current smoker, and looked at the overall risk. So I don't think there was a specific time frame associated with it. The next question is, I think that diabetes can precede cardiovascular disease or vice versa. However, can we generally consider diabetes as a risk factor of cardiovascular disease, but not the other way around? It's a great question. Diabetes is absolutely a for cardiovascular disease for those individuals. It typically it's a cascade. So many of these patients that have cardiovascular disease will have the same overall risk factors. There's so much overlapping between them. So hypertension or high blood pressure, dyslipidemia or high cholesterol levels, abdominal obesity will all increase the risk. So you can see where they all kind of overlap in terms of increasing. So I look at them as comorbidities. So what we see in this, we're using that terminology more and more, that these are comorbid conditions. So be it obesity, which is now a chronic condition, cardiovascular disease, diabetes would all be these comorbid conditions. I want to, with this, what is the biggest barrier or opportunities engaging clinicians so that they do begin VBA or 3As for their patients? Sorry, it's just dialing up. Time, education. The barriers that we see the most and foremost for clinicians is what we see with things such as, again, public health would be like vaccine hesitancy. They're worried it's going to take too much time. They're worried they don't have the skill sets, and they're worried they're going to get people upset. So the key things here is just to say, listen, all we're doing here is just to integrate it within your regular practice. I'm encouraging, if I present to clinicians, so if I'm presenting to nurses or I'm presenting to physicians or presenting to pharmacists, is it's a team effort. So you can engage your entire team. So if it's a family doctor who's presenting to in terms of that group, if they have a nurse or even other staff members, they'll just ask and document in terms of their smoking status, so to encourage them to have that conversation. In the pharmacy, this could be the pharmacy assistants or technicians that can work with them. But the biggest barrier is time that they'll say, but as we're getting over and over, it's only 30 seconds. But I think that they're worried that they're going to open up a can of worms or jeopardize a relationship with patients. But we can show them a lot of the data saying, you know what, the data actually points that they want you. And we see this with a lot of times with healthcare professionals is I'm worried I'm going to upset the patient. But what we find is that if a patient is doing a behavior that they're not overly proud about, and the clinician doesn't say anything about this, then the patient said, well, it must not be a big deal because they never brought it up. So if you actually introduce this one and you get healthcare professionals to do this consistently, you'll see that we'll start to see an increase in terms of the conversation. So when the person is really ready to quit, they know how to get that support. Are there guidelines for treating pregnant women? Yes, there are. If you, I can end up sending that to you, so you can end up following up with me if you require it. And I'm more than happy to, they can provide my email address and I can grab that for you. Are NRT short-acting products only available to be sold in pharmacies under a pharmacist? These can be bought over the counter. So they all addressed, all of these can be bought in a pharmacy. They don't need direct consult. They're over the counter. They used to be behind the counter. They're now over the counter. I would encourage any person that's buying these products to end up asking for support if they're not familiar with it, because again, if they don't use these products effective, they're going to run into an issue. The ABCDEs is SSS. So somebody's asked me to describe those. So these are the Diabetes Canada recommendations for reducing cardiovascular risk. A is to have an A1C of less than 7%. That's a typical target. So we want to get the sugars under control. B is for blood pressure, less than 130/80. C is for cholesterol. So this stands for LDL cholesterol or bad cholesterol. We want to have that less than 2 or a 50% reduction for those patients. D is drugs that we want to end up using to reduce cardiovascular risk. These can include blood pressure medications specifically shown to reduce the risk of heart attack or stroke. And what's really exciting, there's just some pharmacotherapy or drugs that we use for diabetes that can reduce the risk of heart failure, heart attacks, strokes, and risks of cardiovascular death. E is for exercise, 30 minutes a day, 150 minutes a week of moderate intensity. Moderate intensity is what you tell your patients, just enough to get the heart rate going or the breathing going a little bit faster. S, going up, S is for screening for complications, so their eyes, their feet, and their kidneys. S then for smoking cessation, we want to encourage that for all our patients. And the other S is for stress reduction and self-management. So again, to reduce the stress for it. So those are really, really overall important. Recommendations for vaping. This is such a great question, not included with any of the guidelines at this point. I don't see that as being an issue. People ask, can I use e-cigarettes to end up helping the individual quit smoking? There is not significant amount of data to actually show that a person that uses e-cigarette tobacco to be able to end up quitting. I am so concerned about e-cigarettes from the standpoint of of getting younger people end up using it. I think that, to me, my thought is that's one of the reasons why we're seeing this increased uptake in terms of tobacco use or nicotine use. Because a lot of times people will stop being able to afford the cigarettes and then go convert to tobacco because it ends up being cheaper. No specific recommendations at this point. I don't have a problem with patients ending up using NRT to end up supporting it. It's nicotine. Nicotine is nicotine. So using a nicotine replacement therapy to end up helping. Is there any supporting evidence on the use of cysteines for smoking cessation patients with diabetes? No specific information that I've seen on cysteine. If you're not familiar with this drug, this is actually, it's a herbal-based supplementation. There's one company that has it here. They have some success with this individual product. There is some data supported. It's not as extensive as it is with the other agents, because again, it's a relatively newer product that's here. I don't see a problem with patients ending up using it. One of the key reasons that they use it is overall because of cost. I personally don't recommend it for patients. I would typically end up using one of the pharmacotherapies, but I don't see it as really a major issue. Teens is a great question. Pediatrics it's really beyond the scope of this one. I don't see an issue using these individual products, but they're not indicated, so it's really off-label for those individuals. American Academy of Pediatrics has a smoking cessation guideline for use in pediatrics. And I'm at 2 minutes over, Ian. I think I got all the questions.
So there are 2 questions that came in through the chat module that I think are worthwhile.
Okay,
the first one, and they're limited. So the first is, are there any geriatric considerations for dosing?
It's a good question. So it would be for only oral agents for looking at Champix and looking at Bupropion because of chronic kidney disease in terms of function. So you'll see that within the product monographs of these individual agents. I would be concerned about using Zyban in a patient who is geriatrics, and the fundamental reason is just because of the potential for drug interactions for these individuals. So you have to be a little more careful, and they're more prone to those adverse effects of insomnia and dry mouth. NRT can be used. Again, is with a lot of these products, we can adjust. So what I would typically end up doing with these patients is look at how much they're smoking. If you're really worried about it, if there's a lot of frailty in those patients and you're concerned, we can start with a lower dose. That patient would look at doing a reduced to quit, because again, these are many times more chronic smokers. They've been smoking for many years, a lot of times decades. So in terms of those products, I would start at those doses, but do more frequent follow-up. And if they're having issues, we can increase the dosing associated with it.
That's great. So one other question, maybe out of scope, but I'll let you determine that. Another question is, in long-term care, it is required that the NRT be on the PT Mars sheet, yet this is an OTC. Given the benefits of NRT, why is this not covered under the ODB for residents of long-term care?
You don't want to get me started. So first and foremost, I love that it's ODB for people that are from outside of Ontario is Ontario Drug Benefits. So, and I live in Ontario, so I think it's the center of the universe. So, and people from the West Coast love that when I say that. But from the standpoint, there's so significant benefits associated with it. It's the same reason why aren't obesity medications covered for people with diabetes, because this would end up helping to improve outcomes. They still view this as a lifestyle issue more than anything else. I would love to see this covered, but I don't think that it's going to happen under our current environment. So if we can get people to quit smoking, whether they're on ODB through a long-term care or through somebody who's on social assistance or on a Trillium basis, the health benefits for this is so significant. But again, they're really worried about an increase in overall costs. And I have one question that came up. Varenicline and NRT, is it off-label? I believe so, that it's still off-label here, but it has been used from that perspective. So I don't see that as being an issue. And there's a New England Journal, I can send you the evidence associated with it. It's just something to make it aware of. Originally, we thought there was no need because you're blocking the receptor. So why do you end up giving nicotine to these patients? Because it's going to block the receptor, it's not going to work. But it did. It actually increased the cessation rates for the patient that did it. It was a marginal increase, but it may end up helping for those cravings for those individuals.
That is tremendous. Thank you so much, Michael. You covered a wealth of information in just over an hour, and very grateful. Thank you for being with us today, and thank you for everyone who was participating and watching in. As mentioned, recording of today's webinar will be uploaded to CPHA's YouTube channel in the next couple of days, and everyone who is registered to attend will receive a link to that. Now, Michael, don't want to put you on the spot. You had mentioned that you wouldn't mind sharing your slides.
Yeah, I'm happy to do it. So from my standpoint, I'll send you a PDF, Ian, and you can share with everybody.
Perfect. So we'll include a link to that in the description of the video on YouTube so that you can access those easily. And last but not least, I want to thank our sponsors today, Johnson & Johnson. They provided the support for today's event as part of their sponsorship of the 2020 Tobacco and Vaping Control Forum that CPHA hosted a couple of weeks ago. Thank you all very much for your time. Stay well, stay safe, get your flu shot, and maintain your physical distancing and keep wearing those masks. Take care. Bye-bye.
Thanks so much.